Hello, everyone, and welcome to the VDEV CPR Bread virtual seminar. Today, we're very happy to have Lorenzo Casaburi. Lorenzo is the UBS Foundation Associate Professor of Development Economics at the University of Zurich. I want to remind you of the seminar rules. The seminar will run for 1 hour. The last 15 minutes would be a Q&A. At that point, we'll open up the mic for participants to ask their questions live. If you have any questions, just raise your hand and we'll open up your microphone so that you can ask your questions directly. During the talk, please write down your questions in the Q&A section. We will make a couple of pauses during the talk and I will pass some of the questions to the speaker. Please do not take offense if we don't transmit your questions to the speaker live. Notice that you can vote up or down the questions in the Q&A. Needless to say, aggressive or abusive behavior will not be tolerated. And also, Lorenzo has very kindly agreed to keep talking in a separate room after the end of the talk. We'll post the link of the Zoom room in the chat. Make sure to save it. Finally, remember that you can follow us on X and on CPR's YouTube channel, where most talks will remain recorded for at least a few weeks. Also, check CPR's website for more information on the series. And with that, Lorenzo, the virtual floor is yours.
Okay, good morning, good afternoon, good evening. I'm sharing the slides. Can you see them?
Yes.
All good. Okay, so thanks very much for having me. It's a great pleasure to present at this long-standing virtual seminar. So thanks to the organizers for inviting me. I'm presenting this paper, Copays, Selection and Impact, Experimental Evidence on Health Insurance in Uganda. And this is joint work with Cramer from LSE and Jack Willis from Colombia, Sciences Po. Okay. Let me hide my controls. Perfect. Okay. So in many low and middle income countries, basic public health care is free, at least officially, or heavily subsidized. However, the quality of this care tends to be low. As many studies have documented, you can think of low staffing and absenteeism, limited drug stock and quality, waiting times, and many other factors. In response to this low care, there is often a large private sector that is very heterogeneous, with some of this private sector providing better quality, but often being more expensive. And so implying large out-of-pocket costs for households and individuals who use these facilities, and implying that many households forego the opportunity to use this private health care due to the implied cost. So, question for a policymaker is it worth to subsidize health insurance for private health cares in this type of settings? And of course, when we think about giving a transfer that is on a specific item, in this case, health insurance or private health care, a natural comparison is vis-a-vis unconditional cash transfers. Now, subsidizing premiums, for example, for insurance, may have one benefit in addition, that is reducing adverse selection by broadening the pool of households that use a certain healthcare facility. However, critics argue, on the other hand, that lowering costs may also result in overuse of healthcare. In high-income countries, health insurance often has copays or deductibles to attempt to reduce distortions that arise from this type of moral hazard. So another research question of the paper is, in low liquidity settings, like the one we are going to study, do copay reduce distortions, for example, by mitigating this moral hazard concern, or do they reinforce them by reintroducing liquidity constraint considerations that the very insurance products aim to mitigate? In this paper, we explore these questions with a randomized controlled trial in rural Uganda on private healthcare insurance under different copays. We ask 4 research questions. 1, what is the effect of health insurance on health and financial outcomes? 2, does health insurance feature moral hazard and/or adverse selection? 3, how do the answers to questions 1 and 2 depend on the level of copays? And in turn, we use the answer to these questions to try to characterize the trade-offs in insurance design in particular between subsidizing premiums, so the amount you pay at the beginning of the year, let's say, to be eligible for insurance, versus subsidizing copays, the amount that one pays for every visit to the health facility. Let me give you a preview of the results. We find in this context that insurance for private healthcare shifts care from clinics, think of rural, mostly public clinics, to these higher quality hospitals. And it improves both health outcomes and rescoping measures. Using experimental variation in copays, we document that lower copays increase visits to the hospitals for which the health insurance is valid. However, lower copays do not induce differential gains in health outcomes, consistent with these moral hazard concerns. Finally, when trying to understand the trade-off between subsidizing premiums and copays, we find that given the high sensitivity of insurance valuation to copays, subsidizing copays may be a particularly effective way to expand enrollment. People are very sensitive to the amount that they have to pay at the time of use, even for relatively small amounts. Okay, so the paper relates to a large literature on health insurance, work on copay deductibles in health insurance in high-income countries, starting with the seminal RAND experiment. There is a limited but growing body of work on health insurance in developing countries, including a recent review by Pascaline and Radhika Jain, both on the impact and on demand and potentially selection. When looking at demand for healthcare in developing countries, there is a lot of work on preventative technologies, less on copays. Let me point out a recent paper by Buitrago and co-authors that looks at how copays in hospitals affect mortality in Colombia. And then more generally, there is a literature, both theoretical and experimental, that tries to understand the interaction between liquidity and insurance design, including previous work by Jack and me. So our experiment brings together these strands of literature by identifying selection, behavioral responses, and effects of premiums and copays. To the best of our knowledge, this is the first paper that experimentally quantifies trade-off between copays and premiums in thinking about insurance designs. Okay, so this is an outline for the rest of the talk. We're going to start from describing the setting and outlining the experimental design. Then we're going to look at the treatment effects of free insurance. Third, we're going to study valuation of insurance, which our experimental design allows to measure. And then finally, we will combine insurance impact and valuation to perform simulations, understanding selection and moral hazard, and again, trying to characterize some trade-offs in insurance design. So that's the plan for the rest of the talk. I should mention that this is very much work in progress. We have recently started presenting this paper, whose underlying data were collected a few months ago. And so I very much look forward to the questions and throughout, and in particular, the Q&A session at the end of the session. Okay, so let's start with a description of the setting and of the experimental design. All right, so we work with 3 private, not-for-profit hospitals in Western Uganda. So you should think of these as being located in mostly rural areas, but in the town, in the center of these rural areas. 2 features that I want to highlight of these hospitals. The first one is that hospitals provide primary care as well as specialist or emergency care. The second is that they are generally considered high quality compared to other facilities that are available in their catchment area. Okay? So you shouldn't think of these hospitals as providing only specialized or emergency care. That's going to be important for the discussion later. And so you see one is in Kozi, in the central part, and two are more in the western part of the country. Okay, so we develop partnerships with the hospitals and with this company called Streamline. So Streamline provides to these hospitals healthcare management software. The platform is active in about 50 hospitals across Uganda, covering more than 1 million registered patients. And the platform collects rich episode level on healthcare provisions and payments, which we're gonna leverage later in the presentation. Streamline also administers vertically integrated health insurance for the hospitals. So you should think of basically facilitating the implementation of the insurance through this healthcare management software. These insurance products are active in a subset of the 50 hospitals, in about 12 hospitals across Uganda, and have about 15,000 members. Now, our experiments targets new areas for hospitals that were already partnering with Streamline, but so targeting new villages, typically a bit farther away from the hospitals than the incumbents. So let me describe a few features of the insurance product. Again, this is a product that exists before we come, and we're gonna sort of vary some key features in our experimental design, as I will discuss later. So the cost, it's about $7.5 per person per year. It has a copay. The copay is typically $1 for outpatient services. And just to think of the ratio between the cost of the copay and the actual cost of the services, the approximate cost per visit is $8 to $10. We are still estimating it, so take it a bit with a grain of salt, but that seems to be the number of the amount of the uninsured cost for the average visit in the data. It also covers the insurance inpatient services. There is a 30% copay. It's quite rare. So in everything that I'm going to talk about in this talk, we are going to focus on outpatient services, not on inpatient service. Now, importantly, this insurance product is bundled at the household level. So a household enrolls with at least 4 members. And this, as it has been documented in other work, for instance, a very nice paper by Fisher and co-authors from a couple of years ago in AG Applied, this reduces the scope for adverse selection. Okay, so when we talk about selection and consent, you have to keep in mind that this feature of the product. Now, what does the product cover? It covers comprehensive outpatient and inpatient care, including consultations, both with general doctors and with specialists, treatment and emergency services. It also covers key lab tests for infectious and chronic diseases. Think of malaria or typhoid, just as an example. Okay, so how do we recruit? We work in partnership with Streamline and with their mobilizers, and we list members of saving groups in this area, in the broad catchment area of the 3 hospitals. These are standard targets for insurance outreach programs. We select about 3,000 households from them. Most are farmers, substantial food insecurity, so relatively quite poor populations. Most households have children. 90% of the households have children. Okay, so let me give a summary of the experimental design, and then I will zoom in into some important aspects. So step 1, we randomly select up to 4 members of the household, 2 adults and 2 children. Again, the average household size 5.5 or something. So we selected random 4 members that will be considered for insurance. Then we elicit demand for 1 year of insurance under 3 different copay levels: 0, 1, and 2. Okay? Then we administer the rest of the baseline survey. And at the end of the survey, we randomly assign the 4 members that were selected for the household. So it's a household cluster randomization to treatment for 1 year. I will discuss the treatments later. How does data collection work? We rely on 2 primary data sources. One is that we collect survey data for everyone at the individual level, 6 months, after 6 months through a phone survey, and after 12 months with an in-person survey. So each survey covers a 6-month period retrospective. As we will see later, at the end, we also re-elicit insurance valuation for 1 copay type at the end of the 12-month coverage period. Okay. Second, we have data on with unknown data from our partner hospitals, but only for people who are insured. Okay? So these are going to be patient visit level data on services, consultations, drugs, tests, and procedures. We also have some information on triage and consultation records with symptoms, but these are incomplete, so we are going to mostly use them for descriptive work in future analysis. Okay, so we are interested in eliciting insurance valuation under different copay levels. And in particular, we study preferences for insurance versus cash transfers. So we elicit willingness to accept. So basically, in a multiple price list, for each copay level, 0, 1, 2, we ask respondents to choose between insurance and a certain amount of cash, where this amount of cash varies between 0 and 300% of the standard premium, which would be, again, $7 per person times 4 household members. We pay a lot of attention on getting implementation right, explanations, practice with test items, compression checks, showing cash to overcome potential trust issues, etc. Of course, understanding the choice between insurance and cash transfer, so eliciting willingness to accept, is different than asking people to pay with their own money, as it's been shown in large body of work, including very nice paper by Bullinger and co-authors. There are multiple considerations besides this motivation. Sort of willingness to pay is hard to enforce. If you ask people to pay, then you have to come back and make sure that they do pay, and that's tricky. If you are interested purely in market relevance, then maybe willingness to pay is also useful. So there are trade-offs. And indeed, in a small subset, but not so small, 300 plus people, we also measure willingness to pay, and I will have more to say about this later. Okay, so after the baseline, after eliciting this insurance valuation, then we randomly choose one of the 3 copay levels and one value of cash or control. So in 96% of the cases, the value of cash on which we base the choice is 0, meaning that for this case, the vast majority of people prefer insurance to getting 0. Then to keep it incentive compatible, we also have a distribution on other values of X. So in turn, this randomization design implies that we have 4 experimental groups. We have a group that receives free insurance with copay of 0, a group that receives free insurance with copay of 1, a group that receives free insurance with copay of 2. And then we have a cash transfer group, where the amount of the cash transfer is worth the standard premium amount, so about 7 times 4 again. And of course, this allows us to control for income effect that the subsidy to the insurance premium may provide. So each household is assigned to one of these 4 groups, but we have valuation of the insurance for different types, different levels of copays. Okay, and so what our design identifies, we are basically able to identify valuation and impact, valuation for different premium copay levels, and both are going to affect selections. And copays, as mentioned in introduction, may also generate behavioral responses on usage, on healthcare usage. How can we isolate these effects and run counterfactuals? Of course, in mind, we have a 2-stage randomization a la Karl and Zinman, but then we all have one margin which is credit in that basic paper, while here you have to think of multiple margins of insurance design, premium and copay. Okay, so let's think of the counterfactual design. What does our design identify? Okay, so you can think that there's a potential outcome for individual I when receiving insurance with copay C. Okay, so YI1C will be the potential outcome, for instance, the health status when receiving insurance with copay C being 0, 1, or 2. And then the potential outcome if uninsured is YI0. And then to our insurance valuation elicitation, we know for each combination of P and C, the share of households that would select into insurance at those terms. Of course, for any given individual, we only observe one YI for the actual assigned treatment, but we observe valuations under all the possible price copay pairs, premium copay pairs. Okay, and so we randomize essential insurance regardless of demand, and this implies that we can identify the average treatment effect unconditional, and yeah, that's straightforward. And of course, this difference is gonna include behavioral responses to the insurance. Now, we also measure demand, as I mentioned earlier. And so this implies that we can condition treatment effects or cost or other outcomes on study selection. And in turn, we can simulate outcomes and costs under different contracts. So, for example, we can say, what would be the health status if we offered insurance at premium P with a copay C? And this would be the average of the outcome, or the average outcome for for when getting insurance at that copay, weighted by the share of people who would select into insurance for that PC combination, plus the outcome if uninsured, weighted by the share of people who will not select into getting insurance at that PC combination. So we can reproduce this average outcome by weighting the two groups and having information on the share of people signing up under each PC combination. And so in the final part of the presentation, we will indeed do some simulations where we combine treatment effects and demand to get at some interesting insights from this exercise. Let me pause here. Nico, is there any question that you wanted? Okay, good.
No, I think we're good.
Okay, so then I hope the experimental design is clear to everybody. So next, what I want to do is document talking about the treatment effects of free insurance. Okay, so first of all, some basic checks on product knowledge and satisfaction. We find that basically about 90% of in our treatment groups reports having health insurance at the end of the period. It's a small fraction in control group, about 5%. Mostly people get the right copay, not 100%. About half use the insurance that was given in a 12-month period. People are mostly satisfied with insurance, 4.14 out of a max of 5. And about 10% report some problems when going to the hospital. This is typically about charges or waiting times or things like that. Okay, but overall, the level of satisfaction and usage seems quite good. Okay, so now we can run regressions on outcomes. We have two main specifications. In one, we just regress outcomes on a binary indicator for having insurance, for being in it's ITT, so for being in a group that is supposed to receive free insurance or not. We pull data. We have data from 2 surveys, each covering a 6-month period. We cluster at the household level. And again, the sample is the 4 randomly selected members of the households. I forgot to mention, this is typically, we certify on 2 adults and 2 children where possible. Okay, and then in our second specification, we break the treatment by the 3 copays groups. So now we have 3 dummies, each for having free insurance with copay 0, free insurance with copay of $1, free insurance with copay of $2. But otherwise, same specification, pooling the 2 surveys together. Okay. First of all, do we see usage responses or healthcare facility usage response? Yes, we see that access to this private healthcare insurance more than doubles visits to insured hospital. So from a control mean of 5% plus 7 percentage points in the treatment group. And there's a substitution to hospitals away from clinics. The Ugandan Ministry of Health classify clinics in different levels. So you can think that hospitals are at the top, and then there are lower levels. And you see reduction in both, I think this is number of visits at the individual level, the unit here is individuals, and this lower reduction in these lower level clinics. And the increase in hospital visits is twice as large with 0 copay than in a $2 copay, consistent with what one could expect. However, there is no difference in substitution. So the reduction in other clinic visits, it's similar between different treatment groups. Okay. Now we can also look at the outcome of healthcare seeking overall. Is there any facility visit, or does the individual reporting visit the number of facility visits across all the different levels of clinics? Okay, and so we see that overall treatment reduces health facility visits and also health expenses in the 4th row of the table. Again, this is per individual per semester. Now, this reduction is largest for a $2 copay, especially on the number of visits. And so you have to think here that there are multiple margins, right? One margin is that, if I get better care in an early visit, if I go to the hospital early rather than maybe trying the clinics first, this may reduce the need for further visits. The other is that for groups that don't have it entirely for free, or for services that may require a payment in addition to the services covered by the copay, costly hospital visits may constrain future visits. And third, there could be different costs per visits condition on the services used, or at least on having a visit to, let's say, a hospital versus a clinic. So this is now bundling these 3 effects. Okay. When we look at administrative data, okay, we see that the difference in health seeking at insured hospital is clearly visible and consistent in the admin data and consistent with the survey data, and it's consistent throughout the year. Okay, so it's not the case that there's a big jump in use. Maybe people just use the insurance at signing up, and then it flattens out. It seems to be pretty evolving over time. The biggest difference comes from the 0 copay versus the $1 copay. And now, how do we interpret it? Is this a better health? Is this leading to better health? Is this potentially consistent with the overuse and some wasteful health seeking? That's what we're going to look at next. Okay, so we find that free insurance leads to improved physical health and fewer worries. We have a health status ranking today, which could be subjective. We have a reduction in the number of sick days. We have a reduction in the days missed at work and at school. These start to be fairly objective outcomes. No impact on mental health index, but reduction in a worry index that brings together scales of worrying about health, medical expenses, and others. Okay. So it does seem, again, that the insurance leads to improve physical health and fewer worries. Now, importantly, the 0 copay reduces worries the most. If you look at this row, compared to the $2 copay, the 0 copay is somewhat larger. Again, not significant in general, but overall, and this is important, treatment effects on health outcomes are similar across the three copays group. So the copay, a lower copay, seems to induce more visits to the hospitals, but not improving. It does not make a differential improvement on health outcomes like sick days, number of work days missed, or perceived health status today. Okay, there are other outcomes that we consider. One is on risk coping, right? Out-of-pocket expenses could matter a lot if people have to take costly strategies to deal with them. So an overall index of risk coping goes down by 0.15 standard deviations, again, meaning that people seem to be taking fewer costly actions or need to take fewer costly actions. A lower share of people mentioned that they've been foregoing healthcare, and then fewer people mentioned they've sold assets, they've reduced food consumption, or taken a loan. So overall, on the financial side, consistent with other work, sort of providing insurance sort of reduces the need for this costly action. Okay, and again, no obvious difference by copay in this risk. Okay, so let me take stock on this first set of results. The insurance for private healthcare results in substitution of healthcare seeking away from clinics toward arguably better hospitals. And this leads to a reduction in overall visits and health expenses. Smaller copays lead to more visits to insured hospitals compared to relatively high copay, but no difference in the number of visits to other health facilities. And insurance leads to improvements in both health outcomes and risk coping, but not differentially by copay. And so the fact that health insurance is improving sort of this or reducing the need for this financially costly action is in line with other work. After all, health insurance is primarily a financial product. Most studies find the effects on healthcare and especially on health outcomes often not significant, including recently large studies. In our setting, maybe this is entirely driven by the fact that it's a different setting or possibly better quality healthcare facility. We do find improvement on a number of health outcomes, as I mentioned earlier. Okay, with this, let me move to the second set of results, insurance valuation. Okay, so demand is, as measured by this willingness to accept, is high and sensitive to copays. At a regular premium, the x-axis here is in shares, in percentage of the regular premium, so about $7.5 per individual times 4. So at regular premiums, 78% of people say that they would prefer receiving insurance with a zero copay compared to an amount of cash worth 100% of the premium. And this is 64% for a $2 copay. Even at substantially larger amount of the premium, so a substantially larger amount of cash, meaning an amount of cash worth 3 times the regular premiums, 48% still preferred the insurance with a $1 copay to the cash transfer. One point to make here is that the premium itself is probably subsidized. There is a lot of outreach costs to get to these. So the premium is arguably not the market value. And that's why we're interested in demand at higher, potentially unsubsidized levels. Increasing copay from $0 to $2 is equivalent to raising premiums from 100% to 200%. And the results are similar across different hospitals, different elicitation. Two things to notice on this relatively high valuation compared to cash transfers. The first one is that among those insured, we also elicit willingness to accept for a $1 copay insurance at England. Demand there is still high, but a bit lower. Basically, the first one is the demand elicited at baseline. The second one is the valuation elicited at end line. So you see maybe something like 10, 15 percentage points reduction at various levels of the X. No difference by treatment. The second is that willingness to accept is substantially larger than willingness to pay. And so people place a high value on insurance, but are unable and unwilling to pay for it. Okay, consistent with the fact that willingness to pay may reflect some measure of strong liquidity constraints. Again, this is a standard finding with implication for how we should interpret our valuation measures. Again, not a measure of market demand, but rather a measure of taking insurance over an equivalent cash transfer. Now, in the subsample for which we listed both, the two are correlated, which means that while we are not presenting results today, some of the simulations that we are doing later, under some additional assumptions, we could run also under the willingness to pay demand elicitation. Okay, and indeed, in the last 10 minutes or so of the presentation, let me jump to the final part, where we combine insurance impact and valuations, performing simulations to understand selection, moral hazard, and trade-offs in design. Okay, so again, just to recap, two of the major dimensions to consider insurance design are premiums, how much I pay to get the insurance, and copay, how much I pay every time at the point of use. These happen at different times. In particular, copays are about needing money when you're sick. And we care about how they affect outcomes, like health status, but also costs. In principle, health insurance is a fundamental, quintessential example of a selection market. Now, premiums and copays may have an indirect effect on cost through selection into insurance. They could change the type of people who want insurance, different terms, therefore affecting the marginal cost. Copays may also have a direct effect through behavioral responses conditioned on demand. For a given selection, the use of insurance is going to depend on the amount of copay. Which matter empirically, and is there a trade-off between premiums and copays? That's what we are going to explore next. And this is very much, everything is work in progress. This is bold work in progress. Okay. All right. So the first is just restating what we saw before. Demand is decreasing in premiums. And again, demand is measured by willingness to accept. Let me be very clear there. And as premiums increase, therefore coverage falls. We are going to reach fewer people, or we are going to reach more people if we are willing to subsidize premiums more. Nothing surprising. Okay. Now we can also, therefore, compute these simulated health outcomes, which I explained in the design part of the presentation. But just to recap, this will be the outcome for every price will be the outcome when having the insurance at a given copay for an individual who will want the insurance at that price copay point, and will be the outcome in the control group when not having, for an individual who will not want the insurance for that premium copay combination. Okay? And so, as coverage falls, the average outcomes in the population get worse. And this is, can bring together multiple aspects, which we're going to disentangle later. But a first order fact is that fewer people get into insurance at higher level of premiums. And this is just the idea. Okay. However, not only sort of outcomes, I should have been clear, this is minus days ill. So you can think of the Y as being the improvement in health in the period studied by the insurance. Okay, so not only outcomes improve become worse as you raise the premiums, but also average costs become smaller, right? Fewer people, it's very mechanical. And notice that this is true at all levels of copays. So average cost also fall with premiums. So far, nothing counterintuitive. Okay, now we can do the same exercise for where the X is the level of copay. Okay? So here what we see that the number or the health improvement is flat in the level of copay. And this is true. The way you should think about it is that we can do these simulations for different levels of premium. Okay, so the different colors just reflect copay comparison under different level of premium. Okay, so unlike for premiums, simulated outcomes are flat in the copay space, but simulated costs are decreasing. Again, because fewer people use it, but also because there is a behavioral response. And so now we want to disentangle the sort of selection mechanism from the behavioral response mechanism. And essentially, we can break down these simulated outcomes into, I would say, three categories. One is adverse selection. And adverse selection could play a role both through premiums and through copays. Changes in both in either premiums or copays may affect the type of people, the types that select into insurance. So adverse selection in premiums will mean that the marginal cost would increase with the premium. And adverse selection in copay will mean that marginal cost would increase with the copay. Now, let me, since I don't have much time, let me skip the graphs. But here what we find is that the slope of the marginal cost, or the slope is flat, basically. So it doesn't seem to be the case, neither under premium variation nor under copay variation, that an increase in these terms selects differentially worse types. And this is an important result. It's also consistent, to go back to some of the design elements, with the fact that household bundled policies have been shown to be less subject to adverse selection than in that policy that target individuals as opposed to us. Second, when we look at moral hazards, when we look at copay, we can also look at moral hazard. Basically, conditional selection for a given type of person, do we see differential use? Okay. And again, I won't go into the details again, but the fact that we elicit demand for all the premiums and copays, and then we can look at usage for any given type, enables us to separate these two forces, the selection and the moral hazard. So what we find here is that while the adverse selection curve is flat, when we look at sort of the average cost decrease by copay for a given selection, the slope is decreasing. So for a given type, increasing copay from $0 to $2 decreases the gross cost by about $3. And so why do we put moral hazard in quote, just to be clear? What we mean is that there is an increase in use. There is no corresponding increase in health outcomes. However, for example, people are also less worried. Okay, so one has to decide that from a welfare perspective, how much we weight improvements in health versus reduction in worries, and we have not taken a stand on that so far. And then, of course, the other aspect that we can look at is whether the health outcomes are heterogeneous by demand, by sensitivity to copay, by sensitivity to premiums, etc. Now, this is work in progress, and I think we suffer a bit from power issues here, so we still need to nail this down. But so far, we don't find obvious selection based on homogeneous treatment effects, or we don't find differential treatment effects by copay. So it doesn't seem to be the case that either the copay or the premium select people who can benefit more or less from the insurance. Okay, so let me take stock from this simulation mechanism part. It seems that neither premiums nor copay affect selection in our setting. Copays lead to more healthcare. However, there is no improvement in outcomes. And this pushes in favor of subsidizing premiums. On the other hand, subsidizing premiums appears to be, subsidizing copays appears to be cheaper. In coverage terms, decreasing copays by, again, $2 is equivalent to decreasing premiums from $15 to $7.5. Okay, and so there's a trade-off here between coverage and costs induced by this moral hazard. Of course, these considerations are based on our estimates of willingness to accept and not necessarily on this willingness to pay, as I emphasized throughout the presentation. Okay, perfect. So this brings me toward to the final slide. So let me just take stock. So compared to a cash transfer, free private healthcare insurance in Uganda reduces health expenditure, improves health status, and reduces costly coping strategies and financial worries. There is high valuation of insurance compared to cash transfers, but limited ability to pay. There is limited evidence of adverse selection, neither by premiums nor by copays. But there is a trade-off in insurance design. Subsidizing copays is cheaper to induce, to reach a broader set of people, but it may induce moral hazard. That's all I have for today. Thanks very much, and I look forward to your questions.
So thank you so much, Lorenzo. If you have any questions, please raise your hands and we'll open up the microphone so that you can ask the question. Since there's no one raising their hands, let me just ask you, there's just someone from Palash. Hi, Palash. Let me unmute you. Go ahead.
Hey, Nico. Sorry. I mean, you can also ask your question.
No, go ahead. It's fine.
Lorenzo, super cool work. I was just wondering when you were presenting this, there's one question which sort of drives your willingness to pay and willingness to accept demand elicitation stuff as well. But how are you calibrating the exact value or cash transfer that you're paying to the control group to net out the income effects?
Yeah, so this is the value of the premium that the insurance offers before our experiment. So that was a pretty natural choice. Over the course of a year, you could claim it's a relatively small amount. But yeah, that's the value that we use.
I see. Because the reason I ask is the different amounts of copay that you show might also endogenously determine whether I'm going to visit the hospital and then have expected costs coming out of it or not. So when I'm trying to understand your demand elicitation curves, am I sort of just looking at the value of insurance, or there are these endogenous objects that are primarily driving also the total payout that an individual expects from your treatment?
No, so absolutely. I mean, the value of the insurance will depend on the copays, and so does the cost for the insurer. And so our simulations eventually try exactly to figure out these trade-offs, right? And the main point, the main result here so far is that copays do increase use, but this doesn't seem to be improving health, at least on the outcomes we measure. On the other end, given the sensitivity to copays, sort of subsidizing copays maybe allowing for a given amount of money to reach more people.
Got it. Thanks. Yeah.
Thanks for your question.
So Patrick has a question. Go ahead, Patrick. Please unmute yourself.
Yeah, hi, Lorenzo. I had a question about if any more evidence on what kind of visits really kind of increased because of moral hazard. Is it, for example, that it's malaria tests that you can get at private healthcare facilities, or are there any kind of variation you get based on the condition of like the patient and kind of who's going either to the hospital or the private healthcare facility?
Yeah, that's a great question. Short answer, we are working on it. We don't, we have a lot to do before we can present. But the good thing is that we have pretty detailed information on this, both from the surveys and from the insurance admin data. So we know the services, we know exactly for which type of consultation they go to, etc. So eventually we want to be able to leverage a bit more this detailed data. We also collect in the survey, basically additional information on perceived quality, etc., which may be complementary to this other information. But thanks, this is of course super important.
So Drew, please go ahead and ask your question.
Sure. Thank you, Lorenzo. Hope you can hear me. Wonderful work, and thanks for presenting. This is really fascinating, and I look forward to seeing more publications come out of this. I'm wondering if you can speak to what is covered, particularly under the copay scenarios or under the health insurance premiums when it comes to out-of-pocket costs for medications. And I ask because it's striking. I do some work in Uganda as well, and it's striking and logical to me to see people selecting away from or substituting away from public facilities into private hospitals. One of the things that we find in many of the public facilities is that drug stocks are extremely variable, particularly for key essential medicines. And we work in the cardiovascular disease space, where we see that oftentimes essential meds for cardiovascular disease are out of stock about 80% of the time in public facilities. So I'm wondering if you could speak a little bit, and this is just planting a seed as you sort of get into more of these details, but wondering if you can provide a little bit of clarity about what's covered under these schemes.
So absolutely. First of all, this stock out issues in the public facilities come up a lot, and it's one aspect of quality that sort of motivated a bit the work on what's covered. So there is consultations, there is treatment, and there is emergency services. And then there are key lab tests. So as part of insurance, you get like malaria and typhoid tests. You also get, I need to double check, but you also get treatment that is, sort of standard treatment that is prescribed during these consultations. Now, I don't remember if there is some cap on the amount, for example. So I will need to double check that, to be honest. But yeah, the idea is that at least on these, basic treatments, these are covered by the insurance. When you go into, something more specific, it may sort of require additional payments. But basic treatments for malaria, for example, are covered. And we can look again to also similar to my answer to Patrick. We are able to look much more in detail on exactly what you get, at least for the visits to the insured hospital. So hopefully, eventually, I can give a more detailed answer as well.
Giacomo, please go ahead.
I guess, Nico, you can go. I mean, you're the questioner, so whatever. I'm just going to go ahead then. So, Lorenzo, hey, quick stuff. It's basically related to what Patrick was asking, I think. And I think you have up to 2 adults, 2 kids in the survey. But from the administrative records, you probably have, you do have everyone essentially. So do you know anything about what people go in for according to the age distribution? So I'm thinking health interventions for adulter ages are somewhat very relevant even in the very short run. For whatever, young adults, it's probably less relevant. For very young kids, it's actually relevant. So do you know anything? And this could be like just future work. It doesn't need to
be. So I think you're absolutely right. One thing I can tell is that when we break just in the survey data on things like health outcomes, etc., the results appear to be roughly consistent between adults and children. Again, I guess this is a setting where things like malaria, typhoid, etc., matter quite a lot also for relatively young adults. But we could do more. And the honest answer is that we have only scratched the surface on that in the admin data. So we will take up your suggestion.
Amik, please go ahead.
Yeah. Hi, Lorenzo.
Hi.
Hi, Lorenzo. Hi. I hope you can hear me.
Yeah.
Yes. Okay. I had a quick question about trying to understand the demand elasticity by premium and the copay. And I guess the difference is maybe slightly illusory because the copay, obviously, you have to pay each time you visit. So in kind of per dollar terms, it might seem high. But is there, if you think about kind of, households predicting the number of visits that they expect to make, is the demand elasticity then similar, or is there any kind of behavioral response going on with respect to responding differentially to copay and premium? I would have expected maybe the response to premiums to be higher because the payments may be front loaded and they may be liquidity constrained. But yeah, just wanted to.
So there are two things here. One is we can do two things. We can do the basically equivalent amount once we take into account the number of visits, the actual number of visits. Okay, the actual number of visits, if I remember correctly, is about 0.5 per household per semester. So you have to I guess make it an annual term. So we could compute exactly that comparison of elasticity given the actual number of visits. I don't think we ask about the expected number of visits in the baseline, which maybe are interesting metric. One interesting thing is that we also released this willingness to accept at the end of the first year. So if there is some learning, that will pay, and we see to go a bit down, right? I showed it, but not substantially. I mean, it will still be quite large. Now, another point which is important is that the premium is elicited to willingness to accept, while the copay is about something that you have to pay out of pocket. Now, this has to be the case because you can't basically have an incentive where you say, oh, every time you go to a hospital, you are asked, do you want a cash, or do you want to sort of a copay in your insurance, because that would have, of course, huge moral hazard problems. But that's an aspect to keep in mind in this comparison, and that's why I also think that doing some simulations for the subset for which we have the willingness to pay could be also quite informative.
Got it. Thank you.
Yeah, thanks.
Okay, so then since there are no questions, I wanted to ask you, Lorenzo, have you looked at heterogeneity in the willingness to accept? Because we're talking about heterogeneity on the effects, but not on the willingness to accept. And I was just curious about what you find that dimension.
Yeah, that's a very good question. My sense there is that we have some heterogeneity in some demographics. Okay, and so we are still reconciling the fact that. I think it's a plus, because typically what the literature does is looking at heterogeneity in demand by covariates that can predict use. But here with our design, we can actually look at actual use and then try to understand what the source of where the wedge comes from. Maybe some of these demographics are less predictive, at least in this setting, of actual use than we thought.
Okay, thank you.
Thanks you.
So I think if there are no more questions, I think we're just on time. So thank you all for joining, and thank you especially to Lorenzo for presenting and accepting our presentation. Just want to mention that in 2 weeks, we'll have Francois Gerard from the University College London. So hope to see you again soon. And remember that Lorenzo will be joining a separate Zoom room. You can copy the link in the chat, from the chat. Thank you so much.
Thank you very much again for having me. Goodbye, everybody.
Bye. Thanks a lot, Lorenzo. Amazing work as usual.
Bye. Thanks.
Ciao.